Popov. He will talk about the comorbidities in MiECC patients. Dr. Popov, please. The floor is yours.
Dear colleagues, thank you for the opportunity to present our experience in MiECC system. It's a great privilege for me. So in recent decades, there has been a trend towards a decrease in mobility during cardiac surgery. However, complications can still develop, leading to long persistent multi-organ failure, which in many cases is associated not only with the surgery itself, but also with the initial morbid status of patient. In conditions where conventional CPB remains the routine method for cardiac surgery, the roles of complication in comorbid patient increased significantly. This is due to whole complex of damaging factors with accompanying CPB. Triggers the SIRS, ischemic reperfusion syndrome, blood artery contact, and temperature shift in various patients of extracorporeal circuit. This is in turn the accompanying by damaging to end organ and organ failure, which significantly aggravates the initial comorbid status, transforming chronic organ dysfunction into acute and sometimes irreversible. So, which significantly we define a patient in high risk if he has more than 5 points of a Euro score and more than 5 points on the Charlson Comorbidity Index. At least 40% of patients undergoing cardiac surgery are high-risk patients with severe comorbidities. This is our real patients now. Cardiac surgery is now dealing with high-risk patients, and it is forced to compete with endovascular therapy and needs a significant reduction of invasiveness. One of the central positions of my opinion belongs to more physiological perfusion. This use of MiECC circuit seems very encouraging. Meta-analysis show clear advantages of MiECC compared with conventional CPB by reducing 30-day mortality, including complications such as stroke, MI, and renal dysfunction. The advantages of MiECC many times discussed yesterday and today, and its strong evidence, and this all means approved physiologically. However, the diversity of MiECC system and the heterogeneity of patients and outcomes don't allow us to confidently extrapolate this data to age-related comorbid patients. However, the patients' benefit of minimally invasive technologies highlight the need to explore the potential of MiECC to improve outcomes. Here is a story of our effort on MiECC penetration. We have implemented MiECC since 2011, but real progress has begun since 2019. Then we are starting to collaborate with Thessaloniki team and Professor Anastasiadis and MiECC Society. For now, we are using type 3 adjusted extracorporeal circuit. Primary is about 750 milliliters. For reason of our patient safety, it was possible to switch to a type 4 circuit with the inclusion of a hard shell reservoir. The aim of our study is to compare the clinical results as well as the severity of systemic inflammatory response in a comorbid patient who underwent cardiac surgery under conventional CPB and the MiECC system. A retrospective cohort study carried out as a part of our research of our center work and included 760 patients. Inclusion criteria was comorbid status, CPB time more than 90 minutes. Exclusion criteria was emergency surgery. According to the extracorporeal circulation method, 2 study groups were formed with a conventional circuit and the minimally invasive circuit. After the initial review of medical records, 68 patients met the inclusion criteria. Propensity score matching was carried out. After that, the 6 patients were excluded. To analyze the method of extracorporeal circulation in high-risk patients with following indicators, we studied 2 control groups. Initially before the start of cardiopulmonary bypass and 24 hours after surgery. We assessed lactate level, creatinine level, oxygenator index, level of hemoglobin based on 3 hemoglobin. Checkpoints of markers of systematic inflammatory response, interleukin 6, interleukin 10, procalcitonin, STRM1 was at 1 hour after start of CPB and at 24 hours after its completion. We assessed clinical data such as respiratory and renal complication, drainage blood loss in the postoperative period, disorders of hemostatic system requiring correction and blood transfusion, the needs of sympathomimetics, length of stay in the intensive care unit and in the hospital. A comparative analysis of patient baseline characteristics did not reveal statistically significant differences. The same results you can see regarding risk assessment. When comparing the type of surgical procedure, there were no significant differences between 2 groups. The group were also comparable in the main parameters of perfusion, duration of bypass, cross-clamping time, volume of blood loss. Postoperative blood loss did not differ significantly between the study of group. Significantly higher doses of inotropic and vasoconstrictor support were observed in the conventional group, with the most pronounced differences recorded then noradrenaline was used. Intergroup comparison of diuresis rates demonstrates significant differences with comparable doses of furosemide stimulation. Pulmonary injury assessed by oxygenation index occurred less frequently in the MiECC group. Creatinine as a marker of renal damage did not show significant differences between groups. The lactate level, which indirectly determines the adequacy of oxygen delivery consumption balance, was significantly low in the MiECC group. The level of free hemoglobin indicated hemolysis was significantly high in the comparison group. Pro-inflammatory interleukin 6 was significantly high compared to baseline values in both groups. Pro-inflammatory interleukin 6 was significantly higher comparable to baseline value in both groups. Intergroup comparison showed 2 differences at 2 control points for the indicator. In turn, anti-inflammatory interleukin 10 decreased significantly by a second control point in the conventional group, while in MiECC group, its values did not change. Intergroup comparison to interleukin 10 levels also demonstrates a significant difference at 24 hours after CPB. The level of leukocytes, C-reactive proteins, procalcitonin and STRM were significantly higher than the initial values in the control group. In the MiECC group, only procalcitonin levels changes significantly. At the same time, and intergroup differences at 24 hours after surgery was observed in the levels of leukocytes and STRM1. The needs for end organ support did not differ significantly between groups. In the MiECC group, there was a shorter duration of mechanical ventilation, a shorter length of stay of intensive care unit, and shorter length of The need for end organ support dialysis on ECMO did not differ significantly between groups. On the MiECC group, there was not shorter duration of mechanical ventilation, shorter length of stay of intensive care unit, and shorter length of hospital stay. Comparison of hospital mortality demonstrate no difference. So, in conclusion, discussion, the most significant intergroup difference in the frequency of symptomatics were observed in noradrenaline used to relieve vasoplegia and maintain adequate mean arterial pressure. Indirectly, this may indicate a greater severity of a SIRS in hospital in control group. The statistically significant difference in lactate level likely indicate more adequate oxygen delivery in the MiECC group. The use of MiECC is associated with shorter duration of mechanical ventilation, length of stay in ICU and in the hospital. The dynamics of increase in interleukin-6 leukocytes and estrem indicate more pronounced manifestation of systemic inflammatory response using conventional CPB. The decrease in interleukin-10 after 24 hours in the CPB group indicate immune suppression, which was not observed in the MiECC group. CPB potentials with systemic inflammatory response and immune suppression, which together determines a high risk of multi-organ failure. So, limitation of study. Thank you for your attention.
Thank you very much, Mr. Popov, for this very interesting lecture. It seems to be a very interesting roundtable, this one, ladies and gentlemen, talking about MiECC in clinical practice. But we have to move forward to the next presentation. Thank you very much.